Hello, everybody, again. It's my pleasure to invite here in front of you the next two speakers, Dr. Silvana Canjou and dental technician Cristian Petri. A few words about Dr. Silvana Canjou. He is a specialist in prosthetic dentistry, having also a PhD degree in minimal invasive diagnosis area. The private practice is focused on complex aesthetic and functional rehabilitation on teeth and implants, using both traditional prosthetic methods and also innovative ones, focusing mostly on minimally invasive procedures. Dr. Canjou is a co-author for four books, 21 published articles, from which 5 are in ICA journals and 1 PubMed indexed review and article. She has over 55 national and international communication in the field of prosthetic dentistry, implant-supported restoration, and minimal or non-invasive oral diagnosis. A few words about dental technician Cristian Petri. In 2002, he opened his laboratory in Cluj-Napoca, Romania. He further specializes as he partakes to the courses conducted by Professor Slavicek, Master Dental Technician Massimiliano Trombin, Achim Ludwig, and many others. Since 2011, he has been holding lectures and publishing information regarding the fabrication of complex implant restoration with a focus on functional and aesthetics. In 2018, Cristian Petri was inducted into the International Oral Design Group by founder Willy Geller. He is co-founder and president of Dental Initiative Romania, a non-for-profit association with an educational character. He is also the initiator of the TIM Congress in Romania. For today, they have a presentation. The title is Prosthetically Guided Dentistry. What does minimally invasive really mean? Please, if you are ready, the podium is yours. Please share your screen with us. Thank you.
Thank you very much, Cosmin. I will let Silvana to start to share our lecture today with you.
Good afternoon, everybody. We are very excited to be here with all of you today. I hope you have left a little bit more of energy and patience to see our lecture. We will talk about, as Cosmin said, about minimally invasive dentistry, an actual and very debated topic. What is interesting is that we are all gathered here today because of this little virus, and we can freak out about a lot of things, and we can consider a lot of issues that are not exactly the way we want them to be. But I think we should also embrace and see the positive part of being in this situation. And one of the benefits that I see is that it truly allows us to hit the reset button in many aspects of our lives. We are most certainly living through uncertain times, and in many ways the world has shrunk. As you may see, we are all able to be here today from different parts of the world on a given Saturday afternoon. And even if Cosmin did a beautiful introduction of me and Cristian, I would also like to add some little details. So I'm a Romanian dentist. I've studied and worked in Romania for 9 years. I was lucky to be part of a great team in Timișoara. And my professional life is divided in 3 main parts. The clinical part, which I enjoy the most. The teaching part, which I do through the platform learning by doing. High impact learning teaching platform, which focuses on minimally invasive dentistry teaching under the concept of interdisciplinarity. And I have also a research activity. For example, my latest article will be published this July in the American Journal of Orthodontics and Dentofacial Orthopedics. And Chrissy, now back to you.
Thank you, Silvana. As you already know, I'm a dental technician. I have my own laboratory in Cluj-Napoca, Romania. And together with my wife, we have a clinic in the same city. And I'm also an oral design member since 2018. Silvana?
Okay, so minimally invasive treatment options, we all know that have become increasingly feasible for restorative dentistry due to the introduction of adhesive techniques and restorative materials that gives us translucency and fluorescence properties similar to those of natural teeth, like for example hair ceram does. But we have to know that the conventional subtractive treatment approach is gradually being replaced by this defect-oriented additive method. That means minimally preparations or no preparations. And this presentation will show you a number of clinical cases to demonstrate the working protocol for this modern approach. And this slide practically shows you what minimal invasiveness really means to us. Everybody that would like to have such an approach should have some sort of a working protocol. It can be this one, or it can be one adapted to your practice or your clinical beliefs, professional beliefs. The general idea is you should have a workflow that guides you through all these phases in order to control the final outcome. And as you see from this slide, we always start our treatment planning with the prosthetic planning so that we always have our end goal in sight. We don't lose it. And on that note, I would like to guide you through 3 of the most common myths in prosthetic dentistry. The first says that no prep is always better. Well, unfortunately, that is not the case. We all wish to have only non-prep case, but in the real clinical life, we find them very certain. The second myth claims that no prep restoration are more aesthetics, and you will see during this presentation that that is not always the case. And the third myth says that no prosthetic restorations last forever. And on that one, I just want to say that in my opinion, nothing that we do in dentistry will last forever. So at the end of the day, we get to walk the fine line between expectations and reality. Because if expectations don't meet reality, there will be a huge avenue of frustration and disappointment. That is why we have to come up with some sort of a treatment planning algorithm in order to know exactly what the best way for our treatment is. So what the best treatment route would be. Historically, preparations for restorative dentistry have varied from extremely aggressive to minimal reduction, let's say. And today we are going toward a minimal invasive dentistry era with this philosophy in mind that less is more. Less tooth preparation means more adhesion and and clinical longevity. And in this context, I developed this treatment planning algorithm that includes these 3 main criteria: aesthetics, biology or structure, if you will, and function. Of course, having in mind that from an endodontical, periodontal, and radiographical point of view, we have no pathologic changes, or these changes were previously treated and are now stable. You may see it's a very busy decision tree. What does this decision tree do? It allows us to easily figure out if our case can go with a non-prep planning. So if our case is suitable for a non-prep approach or for some sort of a preparation, tooth preparation. And I'm going to walk you through this algorithm. I'm going to do my best to convey a very linear process of things we have to consider when we do our decision, when we make our decision. And let's start singling out the reasons why we prep the teeth. And attention, when I say prep the teeth, I mean minimally prep the teeth. So, for example, if we have bulky dental profile, so by this type of dental profile, there is a slight chance that you will be able to do a non-prep restoration. If you have severe decoloration, if you have form and position deficiencies, if you have asymmetry in the gingival contour or proximal caries or composite fillings that are insufficient. So these are the reasons that guide us immediately to thinking that this case should be treatment planned as a prep case. The same goes when we have unfavorable function. So, and here I would like to point out especially the intermaxillary relationships. When we have severe deficiencies in this area, maybe it would be better to have an orthodontic treatment done before we do the prosto. And if the deficiencies are not so severe, we can think of planning this case and doing some sort of a minimal guided preparation to solve the situation. And you can imagine if on top of these two criteria, we have no structural loss, so no wear of the incisal edges, no loss of the buccal volume, no palatal enamel loss, then we have to obtain our ceramic space somehow. And unfortunately, as you will see, not in every case we can rise this, we can do a suitable increase in the video. So that means that for sure our case will need some sort of a preparation. The other way around would be when the gods of dentistry lie and we have an adequate aesthetics, we have favorable functions, so a function that is not so severely affected. We have wear of the incisal edge and at least wear of the buccal volume. In cases of erosion, we also can encounter loss of palatal enamel. So in this case, we can immediately, as soon as we see the patient, think that this case could be solved with no prep, with a non-prep approach. We get to walk this fine line between treatment planning too extremely or too softly. We are as inefficient if we treat treatment plan too softly as we are when we treatment plan too extremely. We may fall in the trap of being either negligent or over treating our patients. We have to be aware of the fact that dental erosion and dental wear is becoming gaining a place, let's say, in the younger generation of our patients. So there are a lot of clinicians that ignore this situation or that don't realize the severity of this situation and postpone its treatment, either to the lack of awareness, as I said, or to the uncertainty regarding the proper course of action. This being said, nowadays we know that that when our substrate is mainly enamel, we need only these values for our ceramic materials. On the other hand, if our dental substrate is mainly dentin, we should add a little bit more to these values for our ceramic thickness. Today we know that in the posterior area, minimally invasive occlusal veneers that vary from 0.5 to 1 millimeter, made of ceramics, but not only, can be applied to correct the occlusal tooth wear, attention also with exposed dentin, in cases of normally expected intraoral forces. So basically, we know now that we can rely on these values, these ceramic thicknesses for the posterior segments. Another important thing to consider is the color of our substrate and the color that we want to achieve at the end of our treatment. For every color change, we have to know we need this 0.2 millimeters. And let's say that our baseline is an A4 and we want to reach an A1 at the end of the treatment. That means, according to this rule, that we need 0.8 millimeters. Okay, let's say that a very good technician can achieve it also with 0.6 millimeters. But the idea is that whenever we want to make a big color change, we need to have more space for the ceramic material. Another important aspect that the vital substrate, the vital teeth as striate differ from the non-vital teeth, because non-vital teeth often have a severe or a strong discoloration, and that is translated into our clinical life that we need more space for the ceramic material in case of non-vital teeth. And we have to be careful when we have a case that has also vital and non-vital teeth. We always have to have a bigger place for the ceramic materials at the non-vital teeth. So, what is the big picture? The big picture would be that it will be great to plan 2 times so that we can do correctly 1 time. But what about thinking 3 times? And for those of you that would like to approach this type of minimal invasive dentistry, you can do it safely because it's a reliable treatment option. As you see, we have also studies that show us that this type of restoration over a long period of time, you see here up to 11 years, have no technical or biologic complications. And that is valid for posterior segments, but also for anterior segments. You see we have a success rate here of 100%. So you can rely on this type of treatment. And for those of you that are interested, the actual literature, so there is a lot of studies that are published recently that certify all this data. Good. And having all this in mind, I would like to introduce you to our first case. As you can see, we can notice from this first slide that our patient has an incisal wear of the teeth. And what is more obvious is that in the rest position, he doesn't show his teeth. So if we take a closer look intraorally, you may see that not only the incisal margin is worn, but also the cusps of the canines. And if we take a closer look from an occlusally point of view, we may see at the premolar level and at the molar side some extensive wear with exposed dentin, some fillings, composite fillings that are also worn out. You may see some spaces between the teeth, but that is not necessarily bad because it helped us at the end to nicely reproportion the teeth. You may see that we have no loss of palatal enamel. That means this case is not an erosion case, but it is a primarily dysfunctional case. So it's a primary dysfunction that we're talking about and not erosion. The same goes for the lower jaw. You may see here, again, this exposed dentin, the wear composites, and the spaces between the teeth. So if we look at this case through the eyes of our algorithm, I think you agree with me that it's a very straightforward case. That's why I chose to present it first, so that I can better explain to you how this algorithm goes. So from an aesthetic point of view, you may see we have a nice substrate color, we have flat dental profile, we have places between the teeth, so we have an adequate aesthetics. The function was acceptable, so we didn't have severe occlusion problems. We had additionally to these 2 parameters. We had the wear of the incisal edge, and we have a loss of buccal volume. That is how we know that from the beginning that this case we can treatment plan it as a non-prep case. And we will show you how we did a therapy for this case, and after that I will show you we will show you 2 more cases where we apply this algorithm. So we started up with an aesthetic wax-up, and it is very important to know that we as dentists have the responsibility to send in the lab all the information the technician needs in order to obtain this, to create this aesthetic wax-up. As you see, we lengthened the teeth, we closed the spaces, we redid the occlusal aesthetic plane. And it was necessary this situation to test into the mouth to see if that was the good direction to go, and everything was okay. We went forward with the functional wax-up. We did an arbitrarily video increase so that we gain space in the posterior segments for the restorations. We divided the space gained between the 2 arches, and in front we were able to remake the morphology of the frontal teeth, lower teeth. Practically this increase in video that we do it mainly to gain space, as I said, for our restorative materials. Of course, we have some extra advantages with this procedure, and you can do it without any fear, because as you see, we have here a systematic review that included I think 902 articles, and which states as a conclusion that this is a safe and predictable procedure. Of course, we can have some disadvantages or secondary effects, let's say, for this procedure. For example, one of the most common negative effect after increasing a video can be pronunciation problem, especially by the S sound. But you have to know that this normally the patient normally adapts to this situation in 1 and up to 2 weeks. So as you see, other studies are also available that show us that no permanent alteration will be done to the patient's TMD situation. So it's a safe way to go. We did also the functional mock-up. I use this Teflon tape to protect my gingival niche. I often do this spot edge technique so that my functional mock-up lasts better. The same I do also in the lower jaw. And now we have a functional mock-up that I usually prefer, and I would usually prefer that the patient wears this mock-up for minimally 2 weeks. It helps us to see if the aesthetic and functional parameters we calculated at the beginning can be followed for the final restoration. It gives us the chance to check with the patient if he can function, if he can speak, if he can talk, if he can eat, if he likes it. We can test out if our increase in DVO is correct or not. So it helps us a lot. It's a great tool to use in the clinical practice. So after 2 weeks of wearing this mock-up, after the waiting period, if everything goes well, and usually it does, you go on with the treatment planning, with the implementation phase, let's say it like this. And for this case, we decided to restore this affected dentition with no prep restorations, basing ourselves only on the adhesive protocol available nowadays. And as you may see, I just rounded the incisal edges. I just eliminated with a disc the aprismatic enamel, so that at the end I will have an increased bone strength and no problems in the adaptation of the final work. So again, the lower jaw, we did the same. I just rounded the sharp edges with a disc, and I prepared the sulcus for the impression. For this case, I opted for a conventional a polyether impression for both arches, and I sent all the information to the lab.
Thank you, Silvana. Back to the laboratory now. We already know the final destination of this case because we have made the wax up, and as the dentist used the wax up as a guidance, we also use this end information as a start point. Why start point? Because we do a cross mounting, and from this point we will use the working models combined with the wax up or mock-up models. Second step is to mount the models, the master models of the upper jaw with the lower wax up model into the articulator. And from this point, we go to set into the articulator in the same position the lower master model using the byte registration done by Silvana. Next step, which is really important into the laboratory, I create a silicon index of the incisal margin of the upper wax up or mock-up. Why? Because I will transfer this information into the articulator with the upper jaw master model. And with this information, I recheck the position of the incisal margin. I can see where is the incisal margin of the tooth or of the teeth and where I have to be at the end. Beside the phonetic and aesthetic reason is important when I start. I already know what I can do for this case and what I cannot do for this case. We see that there is a lot of space in the incisal margin, but when we go to the next slide and we use also a vestibular silicon index, I realize that I do not have a lot of space for structure and on top to build up the ceramic. The approach is to use lithium disilicate structure for this case, even if that we could use feldspathic veneers here. Now the question is, if I want to use lithium disilicate, can I use press ceramic or I can go to mill CAD/CAM blank ceramics? When we have done this case a few years ago, the laboratory options regarding milling ceramic blanks were limited. And that's why I decided to do press ceramic. But now on the market, we have a lot of companies, a lot of producers who produce this kind of press ceramic or blank ceramics, and the question is, what should I use? Here are some tips and tricks. Is the fluorescence important? Value also it's important or not? You can see a really good comparison between a natural tooth, extracted tooth, and a press ingot from different companies. For this case, I decide to do all the veneers by hand, so I choose to do it analogically because of the lack of space, and then to press all the veneers. After pressing, divesting, and working the veneers, you can see left and right that there is an extra space in the incisal margin that I can use, so I decide to use this space to build up the ceramic for a better aesthetic. In the posterior region, the restorations were monolithic and just 3D stained. Why? Because I have a better strength. Important to know that the glaze parameters are totally different for the monolithic works compared with the build-up works. And when we finish the case, it's important to recheck the occlusion, to recheck the contact points, and then when everything is ready, we can send it to the dentist or to the clinic.
So here we come again in action, the clinicians. Of course, I recheck everything that Christy sends me, and I check it also in the mouth through this process of try-in. I usually evaluate if our plan corresponds to the end result, and usually that is the case. So everything looks good, and we go ahead and adhesively cement these restorations. I usually do it under rubber dam, so I always do it under rubber dam isolation. Very importantly, I recommend that you always check the fitting of the ceramics after you have isolated with the rubber dam, so that no malpositions occur. And then I cement tooth by tooth the restorations, and this is the comparison between the initial situation and the final job. You can see very beautiful texture that Christy and colors that Christy managed to do to this case. For this case, we had, as Christy already mentioned, and we do it often, monolithic ceramics from bicuspids to molar, and partially layered ceramics or feldspatic ceramics from cuspid to cuspid, and that goes also for the lower jaw. So everything looks nice and stable. You may see how beautifully we managed to reconstruct these occlusion planes by increasing the DVO in this patient. And remember, we did no tooth preparation here. And the final occlusion check, usually the final occlusion check, I do it with this very thin occlusion paper, 8 microns occlusion paper, that in the frontal area, and you see that in the frontal area we have no contact at this thickness. As for the lateral areas, so from the canine to the molars, we have strong contacts with this very thin occlusion paper. And this is our final outcome. The patient was happy about it, but it was no surprise because we already know from the planning phase where we wanted to go. So everything was controlled. And this is a recall in 2020. Again, for the moment, the things look nice. Hopefully they will stay like this for a long period of time. And that being said, I would like to introduce you to the second case. You may from the start notice that we have an initially flat smile line because of the excessive wear in the incisal margin and cusps of the upper jaw, of the teeth from the upper jaw. And if we have a look closely in the mouth, you may see that the functional movements, so protrusion and lateral protrusions, still function, but I'm assuming that not for long. So we are very close to having unfavorable contacts in the non-working spaces. That's why we know from the start that we have to do something about it. And if we have a look from an occlusal perspective, you may see this huge dentin exposure in the central incisors, as well as in the molars and premolars surfaces. All the occlusal surfaces are being flattened. So that is a real problem for a young patient. We have to do something about it. And this is an initial X-ray evaluation in 2017. I want to point out that the patient is a dentist and also our friend. And of course, he had a bunch of wishes to be completed. One of them was no prep, so he didn't want any preparation to be done to his teeth, whiter teeth, monolithic ceramics in the posterior areas, as you see. And this is the seated condylar position. You notice the very little space in the posterior quadrant and a great space in the anterior area. And if we were in the normal conference room, I would ask you, what do you think? Could the video here be a little bit more increased? And I will answer that for you, no, because even if we add, let's say, 1 millimeter in the posterior area, that will mean 2 extra millimeters in the frontal area, and that is really impossible. So more than this, we cannot increase the video. And the reason is that this patient has a hyperdivergent profile. So yeah, we cannot do it. More than this, we cannot do it. So Christy, back to you.
Thank you, Silvana. And now back to the lab with a non-prep case, full mouth, and must be done with monolithic lithium disilicate, as you have seen the request from the patient and of course also from the dentist. Silvana did also intraoral scan using a tree-shape scanner of the initial situation. As we can see the space also on the digital workflow, on the first molar, on the occlusal surface, we have 0.3 millimeters. On the second molar, we have no space. So when we have 0.3 millimeters for both of our tabletops on the first molar, it's not little, it's a lot of, it's not enough to do any kind of restoration. What can I do in this case? If I check the producer indication, as also Silvana told you, I need at least 1 millimeter for each tabletop. So together will be 2 millimeters. If we increase the DVO with 2 millimeters in the posterior region, yes, we can do in that moment, but we cannot do this case because also Silvana told you why. Literature is showing us that we can be on a safe side on 0.8, 0.6 millimeters for a tabletop. But also, we need space for both of the tabletops, not just for one. And we still do not have this kind of space. Back to the idea, no prep, no increase of the DVO, but to do my works in lithium disilicate at 0.2 millimeters. Can be this done? What we can do? Solution to do a wax up, this time digital, and then we'll see after. As a start point, we import the intraoral scanning done by Silvana, and we start to do the digital wax up. During the digital steps, it's very easy to check with the tools that we have, the limits of this case and the options and possibilities of the materials. As you can see, there is a lot of space for the central area, but there is no space on the first and second molar in the occlusion. What we can do, the limit option was to increase the DVO with 0.9 on the articulator, but also in this moment on the second molar, we have only 0.4 millimeters for both of our tabletops. So still 0.2 on the second molar, 0.2, 0.3 on the first molar. Still a lot under the minimal thickness that I need to do this kind of case. The wax up, it's a additive digital wax up. When we do it as the first time, everything looks amazing. And we think that all will go easy and will not have any kind of problems. But as Silvana told you when she started the lecture, let's think 3 times, plan 2 times, and just do it, if it's possible, just 1 time. Silvana, back to you.
So after I received the digital wax up from the lab, so the printed models, I mean, I did this normal functional mock-up that I always do. And it helps us, this preview that the patient had, helped him decide that he's okay with having a little bit thicker teeth as normal. As you can see from a functional point of view, we were able to achieve our goals. So these are the images with the prep teeth, let's say. It was actually like the first case, no prep. We just rounded, I just rounded with the disc, the incisal edges and the sharp margins. And these are practically the teeth before scanning them. I chose to scan the case, but so that I was sure that Christy could manage this case, I also took 2 impressions, conventional impressions, and again I sent every information that I had to the lab.
Thank you, Silvana. We know that we can manage the analogic protocol for this kind of cases without any kind of problems and with the success at the end. But we know also that thin occlusal ceramic onlays are very fragile and they may fracture during wax up or analogic, even on digital workflow. That's why, what can I do in this kind of cases? Should I choose to do it analogic? But we all want to do it digitally because it's faster. Can be done digitally, can be done in an analogic way. How do I take my decision? We have, as you can see, no prep teeth. The image on the left, it's a non-prep molar from of this case of this patient. We have also to change the color. This was one of the requests from the patient. So we need extra space, but we have no prepped teeth. Also, as you can see in the middle of the screen, we have areas with undercuts. Can I insert a crown, a V-shaped crown on this kind of natural teeth? Silvana must prepare the teeth. I will not do this kind of case. But
the answer is no.
At 0.2, 0.3 millimeters, and without no prep teeth, it's impossible to mill a crown in the digital workflow. And the options that I have received from a friend of mine, Ciprian Panaite, who's working in Bucharest, and I want to thank him for this information. This kind of approach was done by August Bruguera in 2016. The option was to duplicate the teeth and to do them from investing material and build the thin crowns, the thin veneers in wax directly on the investing material without removing them from the model. We check the guidance in the way that every tooth has his function. After that, step by step, we create the final wax up, the final shape of the teeth, 100% morphologic and 100% functional. We are not always fully digital, even if we want to do it full digital. Our brain and hands are the most important tools today, even if the digital tool is one of the biggest tools in the laboratory today. So my idea, select your case, select your tools, and you can win. Going next, one tip and trick is to know that the wax weight, because now when we invest, we do not have only the wax, we have also the investing material inside of our crowns and veneers. Also, another tip and trick for today, it's the pressing protocol is really important. Why? Because we have this investing material inside, and my recommendation for you is to do a test before any kind of this case. Also, when we start to divest the pressing, you can see that the veneers are really thin, and you have to be very, very carefully. I recommend you to use as a start 110 microns aluminum oxide, and then to finish the case with glass spurs. Now, we have thin veneers, we have really thin crowns, but even if they are not on the prepared teeth, we need to check the fitting and to be sure that the crowns or the veneers are really good and we have no issues. If we check those two images, an overlapping of the natural tooth from the model with a non-prep crown show us the replaced volume that we have to change. For example, on the cusp we have 0.4, 0.3, and on the rest of the surface is just 0.2 millimeters. Pay attention also after pressing to the tools that you are using. It's important to know the speed and the type of the grinding tools that you use. In this way, I was able to obtain, using this kind of protocol, I was able to obtain really thin crowns, 0.2, 0.6 millimeters, without any kind of issues. But let's remember that on the second molar, we have had 0.37 millimeters for both of our molars. As you can see on the right side of the screen, on the red circle, we were able to obtain 0.16, 0.18 millimeters for each, let's say, V-shaped crown or V-shaped tabletop. With this procedure, we can obtain incredible thin restorations without any kind of problems. Now that we finish our monolithic restorations, it's time to glaze them to have a really good aesthetic result, even if they are monolithic. Regarding the glaze protocol for the monolithic restorations, I can share with you two types of options. First, it's called the three-step technique. When we apply on the first step the stains and the colors on our restoration, we do the sinterization. Then the second step, we do the correction, color or the stains. And at the end, with the final sinterization, we do the glaze to cover everything and to be sure that we have the colors on top. Second option that I can recommend you for monolithic kind of restorations, we can do this all at once. We apply the colors, we apply the glaze in the same time, and we just do one firing. After we have the final restoration ready with glaze and stain, you can see that we have the non-prep teeth. We recheck them all the time on our non-prep teeth to be sure that the fitting is correct, the occlusion is correct. But also we have frontal region when sometimes the request of the patient or the request of the dentist, it's higher compared with the posterior regions. And I prefer to do a cutback or to do just thin veneers and start to build up ceramic. For the example, you can use on the Haas ingots, you can use Heraceram 750. And my recommendation when you start to build up ceramic on lithium disilicate, try to use all the time one-time build-up, one-time sintering technique. Why? Because in this way, you are able to keep your value on your works and don't lose it and obtain gray shaded restorations. One good tip and trick is you can see on the screen the firing protocol that I use for one-time sintering, one-time build-up technique. Now we have the finished works, they are ready. We check them again on the model, we check them again on the dies, we check the occlusion, we check the function, the contact points, and we are ready to send them to Silvana with the mention that, Silvana, take care please, they are really thin, 0.2, they are monolithic, be careful.
Yeah, so with that in mind, I went on, of course, with my normal protocol, but I was very careful with your restorations, Christy. I managed to cement everything in place without breaking any one of it. You may see, again, we have, like Christy told you, monolithic ceramics in the bicuspids and molars, and partially layered ceramics for the frontal area. We have double veneers for the central incisor and lateral incisors, and V-shaped crowns for the canines. The same protocol also in the lower jaw, so everything was cemented carefully. We, when we look at the occlusal planes, we can see that we managed to re-establish them. We re-established the morphology of the natural teeth, and you may see also the protrusion and lateral movements that are okay, and we can evaluate these movements also in this short video. You can see we obtain a lot of space for the non-working areas so that our patient can function very good for the next years. Do you think that this treatment will last forever? I don't, but for the next years, I'm sure it will be a good one. So our final result and comparison between the initial situation and the final outcome recalled in 2020, some months ago, before this corona crisis started. So this is a radiographic evaluation from some months ago. Everything looks nice and stable. We are happy about it. But if we were to look critically at this case, I would say that the volume of the upper teeth is a little bit too much. And when we put this case in the context of our decision tree, you may see that even though we had adequate aesthetics and some sort of a structural loss, so the wear of the incisal edges, that was not enough to plan this case as a non-prep case according to our decision tree. So if I would have followed this decision tree that told me that I cannot increase the DVO, so I have an unfavorable function there in occlusion area, I have no loss of buccal enamel, I have no loss of palatal enamel. So all these phases guide me to the idea that this case should have been a prep case, a minimal prep case, and if I would have ignored the wishes of our patient, I could have prepared maybe a little bit of the buccal aspect of the teeth, let's say 0.2, 0.3, so that we reduce the buccal volume. And for the posterior area, maybe an orthodontic intrusion was suitable, or just reduce a little bit of some of the occlusal areas in order to minimize the space needed in the front for the palatal veneers, so that at the end we could have had slightly thinner teeth. Okay, that being said, I want to walk you through the last case of today, and you can see this that from this picture it is clear that we have severe structural loss of the remaining teeth tissue. We have failing prosthetic reconstructions. We have over-prepared teeth. So basically, it's a complicated case. But even what I want to say that even these sort of cases, you can approach with a minimal invasive treatment by relying very much on the adhesive techniques nowadays in order to maintain as much structure, healthy structure as possible. And that being said, again, having a look at this case through our algorithm, through our decision tree, you may see, of course, that aesthetics was inadequate, that function was not favorable, and only these two elements guide us directly to thinking that this treatment, this case will be will need some sort of a preparation, even if we have so much tooth structure loss. So we have incisal wear, we have buccal volume loss, we have palatal loss, so palatal enamel loss. So even though we have so much loss because of the aesthetics and the function, we know it directly, immediately as we look at this case, that we will need to have some sort of a preparation. And this is our functional mock-up in 2016. What does this functional mock-up for me? It tells me what my end restoration, what my final restorations will look like. So I know the tooth length, the tooth position, the volume of the tooth, and what do I do next? I calculate how much ceramic thickness I need for the final restoration according to the criteria I mentioned at the beginning of the presentation. So I know exactly how much I need to prepare from this mock-up in order to gain the perfect space for the ceramic. Not more, not less, just the perfect place for space for the ceramic. And I did that, and this is the result after preparing through the mock-up. You may see that some parts I just barely touched the teeth. Some parts, like for tooth 2 I reduced a little bit more. The next step is was to remove the remaining composite material from the mock-up and to reconstruct the teeth with a composite filling, and in order to be able to make an adequate and optimal, let's say, preparation design. And you may see here different preparation designs, from veneer designs to partial crown designs to crown designs. The same was also done in the lower jaw. Here is a combination of no preps, of minimal prep or prepless, if you will, of classical preparations for the teeth that were already prepared by another dentist before me. So again, I gather all my information and I send it to the lab.
Thank you, Silvana. We already have seen the protocol for analogic and digital, and always it's important to know the final destination. That's why we use the information from the wax-up or for the mock-up into the laboratory. We scan the wax-up, we scan the prepared teeth, or we import them directly from TreeShape. And with the digital steps, we create really fast our shapes, and it's really easy to check, and we check in the same time the occlusion and the shapes and the function. I'm sure that the occlusion is fixed because we work with monolithic restorations on the posterior region, and as you can see on the bottom area of the screen, from CAD to CAM, and with the touch of a technician, we can copy the wax-up, the digital design, and then we can create a really great work in no time. All those STL files that we have now, we can mill them. For example, those days from monolithic ceramic blanks, for example, amber mill, and we can mill really fast, the wet milling. We have a lot of options today, and why it's so nice, this new material, not only because we can mill it wet and fully anatomic, is because the first strong point that I can say about the amber mill, that it's very stable during the milling. And as you can see, the margins are really thin, the veneer is really thin, and the margins are perfect after milling, and we have no issues. As a tip and trick for dental technicians, and not only for them, also for the dentists who use chair-side CAD-CAM, just be careful how you cut the spruce after milling if you don't have a wet option. Then after you cut the spruce, it's important to use a stone wheel and remove the excess of the sprue in order to obtain the final shape of the crown or of the veneer. And then even if we were able to mill them at 0.4, 0.5, 0.3 millimeters with the proper tools or with the silicone wheels, we can thin the edge of the veneer under 0.2 millimeters. Also, another good tip and trick for the technicians or for the dentist is that you can polish mechanically the restorations in this moment without doing the final sinterization. As you can see on the bottom of the screen on the presentation, there is one premolar. Left side it's polished, mechanically polished. Right side it's exactly how it looks after grinding by the machine. And as I told you, now we are able to mill those kind of lithium disilicate veneers or V-shaped crowns or even crowns really thin. We can go up to 0.3 millimeters. But even so, with the new tools, we are able to thin this kind of veneers to a knife edge, up to 0.1 millimeter, even under 0.1. So in my opinion, even with lithium disilicate veneers or restoration, you can do really nice and good veneers. Another tip and trick for today When we use this kind of new blanks from Amber Mill is that they have a unique feature. From only one blank, we can obtain 4 different opacities, just increasing the temperature. If we go to the next slide, we can see that, for example, if we want to have an high translucency crown, the HT codification, we do the co-firing at 815 degrees. If we want to have a higher opacity because our veneer or crown is too translucency, have too much transparency, we can transform our work by raising just the temperature at 825 without remilling or redoing our crown. So it's fast, and we can do also chair side, this kind of technique. If we want to obtain a medium opacity veneer or crown, we just go into the furnace, we increase the temperature at 860 degrees, and we have the final result. But attention, this procedure is irreversible. As you have seen in the first 2 cases, I was analogic. Now I want to be digital because the case is letting me to do this time. I have enough space, but with the help of the digital libraries, it was really easy to create the occlusal shapes of the restoration. Compared with the second case, where everything was done analogic, here I was faster. And everybody can do this kind of case, just copying the shape of the teeth directly from the library. When we have the STL files, we mill them, as you have seen. And then, using a golden powder, we can check the shapes to be sure that the morphology is in the way that we want or in the way that we like. Next step, at the end, is the customization of our monolithic restorations using the 3D effect or the 3D technique for the stain and glaze. Full monolithic on the posterior region, no risk of chipping, is the kind of restorations that I like to do. But let's see a few steps how I can create from a monolithic restoration which has just one color to obtain a 3D effect on top. Today, using the new stains and shades from Mayo, which is not glazed, actually it's a liquid ceramic, we can obtain really fast, realistic and natural teeth because it's easy and everybody can do it. You can see the steps using different kind of colors and the shades for this kind of restoration. This protocol with monolithic restorations goes perfectly from premolars to the molars. But in the frontal area where we have or where we want to have a better aesthetic, it's we recommend to have a build-up restoration. As you can see, I always like to do one-time build-up, one-time bake technique for the same reason that I told you that on the lithium disilicate restorations, when we have a substructure of lithium disilicate, we don't want to lose the value of our end restoration. Even with this protocol, you will see that we can obtain a really good color with internal effects. And I consider that the protocol or the procedure, it's offering you a lot of possibilities. But in the same time, using the protocol of the cross mounting, when we have a wax up or we have a mock-up, when we have a silicone index with our wax up, and with the one build-up technique, we are able to achieve the perfect and repetitive position of the incisal margin. In the same way, we are sure that the function of our cases is exactly as it was on the wax up or on the mock-up. So with the help of the digital tools and the protocol that you have seen for those 3 kind of cases, we can be precise, we can be fast on the posterior areas using the digital workflow, and with the help of the good knowledge, we are able to be unique on the frontal areas where we need to do more aesthetic or where we can do perfect natural teeth, not just made by the CAD/CAM. At the end, with the help of the polarized light, you can see the internal effects that creates those kind of unique restorations.
And with that being said, I just want to show you some radiographic images from before the treatment and from some months ago, again 2020. Please have a look of how nicely this ceramic work that Christy did integrates with the soft tissues. And I would like to say that this type of treatment approach was a really life-changing one for our patient. So we just want to conclude with by leaving you with these big recommendations that should help you to be as conservative as possible, to maintain as much as possible the biologic tissue of the patient, but at the same time to obtain aesthetics and function that will last long. So in order to be predictable, we recommend that you follow these recommendations. And that being said,
I have another recommendation for all the dentists. Now, because it's the coronavirus, you have one more reason not to prepare the teeth. But using this protocol, you can see that you can approach all kind of cases using this type of protocol, not only for minimal invasive cases.
Clearly, I don't see myself upon that list. She said, where'd you wanna go? How much you wanna risk? I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale bliss. Just something I can turn to, somebody I can kiss. I want something just like this. Something just like this. Oh, I want something just like this.
And this being said, we would like to thank you all for your patience and for your attention today.
Thank you very much.
Thank you both of you for your presentation. Very demanding cases with very good results and indeed minimal invasive. About question and answer, I saw Silvana, you put a question and you answered too, like video. That's one of the problems for this online congress. You don't have the contact eye with auditorium.
Yeah, unfortunately.
Exactly. About the question from the auditorium, what material do you use for making the mock-up?
Normal provisional materials. So I use many companies, many different provisional materials, because I find that every product has advantages and disadvantages. For example, I don't know, when you have a dark substrate, when you have a deep discoloration, I like to use 3M because it's a very opaque composite material. When I have very thin veneers or very little preparations that I did, and I want that the mock-up looks very naturally, I use DMG provisional material. Or Voco, again, I like a lot. So I vary these materials according to the teeth that I have and to the thickness of the mock-up. I hope I answered good to this question.
Yes, sure. Thank you. And one more question. I think it's for both of you. How do you register the scan and transfer the info regarding increasing the video in the digital workflow of a full mouth rehabilitation? How do you scan and transfer the info regarding increasing the video? in digital workflow?
If I may answer on the left side, there are different procedures depending on the software, design software that you use, and also on the scanner that you have in the laboratory. But to be short, to be fast now, it's that we scan the mock-up, we scan the prepared teeth, and then we overlap everything. It's important to have as many points possible, so the software or the manual alignment can be done without any kind of issues or errors. And if we receive them from the dentist, from the intraoral scanning, we do the same thing, except that we do not scan again the model or the mock-up.
And if the question were referring to the initial situation, so before we do the wax-up and the mock-up, I usually scan the seated condylar position or the centric relation, if you want to. There are some cases like the first one where we increase and most of them are like this, we increase the DVO arbitrarily, only with the minimal space we need for the restorations. And there are cases like the second one where we didn't do any additional increase of VDO. I just scanned the CR position, so the seated condylar position, and from the first contact in that position, we did the rest of the mock-up, let's say the wax-up and the mock-up. So basically, I always scan the intermaxillary relationship that I want to have. So either centric relation or maximal intercuspidation, whichever you work in. And after that, most of the cases go with arbitrary increase. So the technician increase the VDO with the thickness for the future ceramic material, the minimal thickness that he needs.
Thank you for your answers.
Mm-hmm.
No more answers for you. Thank you for participating at our Congress.
Yeah, it was a great pleasure as always. Hopefully next year we see us also live, because human interaction is always better, in my opinion.
For sure, next year. Yes. Thank you again.
Cosme.
Thank you.
Thank you, Silvana.
Thank you, Pretty.
For all participants, please stay with us for a few minutes, for a few seconds. We have a closing ceremony in a few moments, please. Don't leave this whole one. Thank you.